very warm welcome and good afternoon to all of you joining us once again for another Arthrex Ortho Engage Coffee Room series. Before we begin, I'd like to start with some information and housekeeping rules to ensure a smooth and trouble-free program. At this point, I'd like to inform all participants that this session is being recorded and will be available on arthrex.com, as well as will be broadcasted live on social media platforms such as youtube.com. I would like to now take this opportunity to welcome our esteemed international faculty, Dr. Luke Ciccinelli, who's joining us from the beautiful city of Vigo, Spain, where he currently applies his trade. Dr. Luke is a specialist in disorders of the foot and ankle, a product developer, and an internationally recognized speaker with over 50 publications to his name and a wealth of experience and knowledge. We are very proud to welcome you back to this platform. Prof. Naassif, Mohammed Naassif, specialist foot and ankle surgeon from Cairo, Egypt. I've had the privilege of working with Dr. Naassif for many years, and I've been exposed to his immense knowledge as well as his natural love for teaching. An active committee member of internationally recognized societies such as ESICOS and AFAS, and an equally impressive background with experience from all over the world. We thank you for your continued support. Gentlemen, thank you both for taking the time to be with us again today. Your support and contribution is highly appreciated. I'd like to now take this opportunity just to thank our healthcare practitioners from across the globe for their courage, compassion, and dedication during this global crisis. We thank you for your commitment. As you can see, we have reached the end of our Ortho Engage series. We have 2 sessions remaining, which will be hosted by our European colleagues tomorrow and Friday. I wanted to take this opportunity new orthopedia platform. Going forward from here, Arthrex has taken the initiative to design an online platform for teaching, and our official landing page called orthopedia.com is not only a platform where we would be showing our virtual training seminars, but is a dedicated website not only for surgeons but intended for healthcare practitioners who are working in the musculoskeletal medicine field, and for anyone who wishes to gain additional knowledge on orthopedic problems and possible solutions. So for further information on any additional future webinars, you can visit orthopedia.com/webinar to gain direct access. Before I hand over to our moderator for today, Dr. Luke, I'd like to just cover some basic rules for the session. Please ensure that your microphones are muted at all times. And then we will be having a Q&A session where you'll be able to post your questions either to the email at orthoengage@gmail.com if you're visiting us from outside the MS Teams platform, or if you're inside the MS Teams platform, you can utilize the chat option. So Dr. Luke, without further ado, over to you.
Thank you so much, Michael and Ali, for the support as well. And I would just like to second the very nice introduction of Dr. Naassif, and just add that I've always been impressed by his ability and dedication to stay on the crest of the wave, so to speak, not only as a surgeon and an educator, but really as a perpetual student of all that we're learning. So I'll turn it right over to Naassif. You have a wonderful lecture lined up, everybody, and I'll just go through a couple of housekeeping rules and we'll get started. So basically, Dr. Naassif has his lecture broken down into 3 sections, and we'll follow each section with a short Q&A based on that session, and then at the end, we'll kind of wrap it up with a Q&A. And so I'll moderate the discussion by fielding your questions, and we only ask that you try perhaps to separate your questions into the following categories, which will follow Naassif's lecture very well. So instability with fracture considerations will be the first subset. And then acute, micro, and chronic instability considerations will be the second subset. And then the internal brace and augmentation considerations will be the third. And then in general, during the final wrap-up Q&A session, we could discuss other things such as peroneal tendons, global instability, subtalar joint instability. And really the take-home message here is that we're here for you. Arthrex is a wonderful commitment to medical education, surgical education, and we're hoping to have a very engaging conversation. And please send in whatever you like. In the order above preferably, and we will do every bit we can to have this be a really informative and engaging session where everyone takes home both an overall view of ankle instability, but also gets your questions answered. So, Nassif, the floor is yours. Thank you so much.
Thank you, Luke. It's always a great pleasure and honor to be here with you guys, and you did me miles of you heaped upon me miles of credit, which I do not really think I'm due. So we're trying here to talk on ankle instability, and that's such a huge topic, and so we're going to try and focus on specifically the lateral ligamentous type of injuries in particular. These injuries are one of the most common injuries, and as we were talking, Luke, last time, these are my disclosures. I do have to show them here, and I do think that a certain part of this particular lecture is pertinent to these disclosures in particular. Now, I will try to give this talk as a general overview, and as we said, that ankle instability is a rather huge topic. What I would be particularly interested in is to try and avoid the pitfalls, at least in my parts, in my region. We see a lot of pitfalls that are associated with the diagnosis of lateral ankle instability. We try and look at the indications for performing the reconstructive procedures and know the most recent evidence-based management protocols, if there are any. As we said, usually any lateral ligament injury talk usually starts with these amazing numbers. And I'll just draw your attention there to 1 million sprained ankles are seen by physicians, and that's in the US alone annually. So these are huge numbers. Now, even more staggering is if these ankle instability problems are mistreated, 40% might result in persistent problems. So that's really a huge number there. Sprain, it can be overstretch or it could be a complete rupture. I'm not going to bore you much with the ligamentous anatomy. It is a little bit pertinent, and we'll show you in a while. We do know that classical teaching, we've been taught that there are these 3 ligaments, the ATFL, the ITFL, and the CFL. These are from the front anteriorly. But we will see in a while that kind of descriptive terminology has been turned a while. And at the back, you have the PTFL. Now, the anterior talofibular ligament, that's the true collateral of the ankle in ankle plantar flexion. That's why it's the one that gets most commonly injured. While the calcaneofibular ligament, it is tight in extension and lacks in flexion, and it's usually not a part of the reconstructive procedure. Now, let's start off with the acute lateral ligamentous injury, the acute lateral ankle ligamentous injury. So when a person walks in, one of those 1 million in the US, so they walk into your ER, you should start off by excluding that they're fractured. You should adhere to these Ottawa ankle rules. So on the lateral side, you look at the tip of the lateral malleus, and you should look at the base of the fifth. Are these points tender? Medially, you look at the lateral, the medial malleus, and of course the navicular. They do say that it's best to be done again at 4th or 5th day, and remember that timeline because we will use it a little bit later on. Now, we all know the RICE, the rest, ICE, the compression and elevation, but is there any evidence to it? Well, to be honest, there's insufficient evidence to prove that RICE actually does work, but we all use it, and even more so, as we will see in a while, that would remind us not to cast. Because is there any role for casting? And especially where I come from and in our region, I was classically and historically taught that if you have an ankle sprain, you cast these guys. Long-term immobilization and a systematic review, it should be avoided. And if you do cast them, it should be within a few days, maximum of 10 days, just to allow for that ankle to heal down and the swelling to subside. That particular paper went on and talked about the surgical, that most of these patients, they should not be treated with surgery, and they would probably be better off with bracing. And we know this slide, it's because most of these ligaments, whether it's the acute lateral ankle ligament, whether it's the Achilles, any kind of ligament, they heal better when they are with motion as opposed to if they are suspended or in a cast. And that was the idea behind the physiotherapy. And you can look it up in literature. Physiotherapy does not just mean that you write up a note for the patient and you say, okay, go to your physiotherapy and I'll see you back in a month. Because there are certain protocols, as you can see here, and they're very eloquent, and they are actually take a lot of effort. So you have to be in touch with your physiotherapist, and some even divide them into 6 phases of very strict physiotherapy procedures. Now, I would like to draw your attention to certain special situations in the fracture situation. So let's say you've done these Ottawa rules and you find a fracture. Is there still a role, or is there still a possibility to get an instability? Well, let's take a look. What about this case? This was a simple Weber C type. As you can see, we fixed it, and then we decided to look on the C arm and give it a Varus test there, a stress test. And you can see that there was a medial deltoid injury. Now, we can debate, and I would like to hear your opinion later on in the question and answer segment. Would you actually repair these deltoid injuries that are with these special situations? In this case, well, not in this particular case, this I used a syndesmotic screw. As you can see here, I used a tightrope. But whatever the method of fixation of the syndesmosis, I now have a very low threshold, and I do open up the medial side. And in more often than not, do I see these superficial and even parts of the deep deltoid are actually stripped off. I haven't done any dissection here. It was just the skin and subcutaneous tissue. And you can see I can actually see into the ankle, and some of these deltoids are invaginated into the ankle joint itself. And so I do not see how these would have healed if we had not touched them. And I think that a large amount of these might develop into a progressive flat foot or pes planus later on by stretching out or attenuating the spring ligament. So that would be after the fixation there. Another interesting case is this one. Now, this guy, he's a 40-year-old manual worker. And he walked into the ER, the resident there, or the registrar. He did the protocol, he did the Ottawa ankle rules, he didn't think that he had a fracture, he actually got an x-ray in spite of that. He said, no, you're free, you're okay, go ahead, go do your physiotherapy and come back in a month's time. Well, the guy didn't come back in a month. He came back to my clinic after 6 months. He was in pain, he was limping. A lot of people branded him as a workers' compensation case. And when I see this, I immediately go for a CT. And there you can see there was a lateral talar process fracture. So the guy did have reason to have pain and instability. And I decided to fix him with a cannulated headless 2.7, but I also added in suture tack because I thought that the ligament was unnecessarily elongated. Another case is this guy. This is a 21-year-old footballer. He's actually playing for first division. And the guys that brought him in, his teammates, they said that, and the physiotherapy of the team, he said that his ankle, he had a collision with another player, and his ankle really looked awful, and they had to return it back to where it was. And these were the x-rays that he got in the ER, just as you can see, even without any bandaging or anything. And they look pretty benign, a Weber C, and you can't really see much there. And I'll tell you that he did have also a CT. I didn't pull those CTs up here, but they were unremarkable. They didn't have any added fractures or any other associated fractures. So you take your fibula out to length. In this particular case, I did decide, and I'll tell you why later on, to scope. Also, I didn't like the syndesmosis. There was a drive-through sign, so I put in a tightrope. And then I looked medially, and also it was opening up. Now, he was a professional guy. He's 21 years old, and as I said, we can debate about this. I decided that, no, that needs to be fixed. And using the scope, I could actually see the deltoid superficial was invaginated into the medial gutter there. So I fixed it, and there you see I looked lateral. And I could see that there was also a lateral instability. Now, classically and historically, we were taught that if you have a fracture, you wouldn't necessarily have a lateral ligament injury. Now, what you might decide, what you might ask, what made me think that I need to do all of this for this really benign X-ray of this really benign injury. It's that word, that keyword. The patient's ankle was dislocated. They had to relocate it back to where it should be before bringing him to the ER. And I think that kind of triggered me off that there's a lot more than meets the eye here. Another special situation, and I see this more in our country because a lot of our children are getting more actively involved, of course, with the corona, not so much now. But before this, they were actively involved in sports. And a lot of these kids are being labeled as ankle sprains. And I didn't, they get the x-rays just to make sure there's no fracture, because we do know in these subset of individuals, these skeletally mature, you're more apt to get a broken bone than a sprain. But these x-rays are usually labeled as normal. And I didn't know about this x-ray except a few years back. This anterior talofibular ligament view. So you have the ankle in 40 degrees or 45 degrees of plantar flexion. You elevate slightly the ankle, and the x-ray beam comes right down on top of the lateral malleus, right perpendicular. And you'll be amazed to find that there might be that avulsion fracture of the in this case, it would be the ATFL and the CFL. Now, it wouldn't really differ much in your protocol of management, but if you do diagnose them as a sprain and they do have these avulsion, they might in a few years' time as they grow develop this instability. So if you do diagnose them wrongly as a sprain, you might return them to physiotherapy and have them walking very early, and they might develop, whereas you would have actually cost them better off. And this was actually published in the JPO in 2015, as you can see there. So it's a nice article. I would encourage you to look it up and actually use that in your armamentarium later on. So going back to basics, what about this guy? He doesn't have a fracture. Do we have an algorithm? Well, this is just something I wrote about, and this is I wrote up, and this is the way I usually treat these patients. If they do walk in, I use the Ottawa ankle rules. If there is a fracture, obviously we would treat those accordingly. Now, if they do not have a fracture, I really look very closely at their ankle, the stability, the swelling, the pain, and I do ask them, even though they're coming in with a sprain, they usually come in walking anyway. I ask them to if they're able to single leg stance on one side, the affected side, obviously. And then I can decide that they might need some functional physiotherapy or a lace-up brace, or a cast maybe for 5 to 7 days. And some people would like to divide these into, for example, grade 1s, grade 2, and grade 3s of ankle sprains. But whatever you do, I am adamant about this. I ask the patient to come in. I have to examine you after 5 to 7 days. I actually tell them that I am not going to be held responsible for you if I do not see you after the 7th day. This is just to entice them to come back. And then when they do come in after the 5th or the 7th day, if they have absolutely no pain, there is no pain at rest, there is no pain with motion, they're moving freely, they're walking into the clinic, then they go back and continue with their functional rehab. I do stay in close contact with the physiotherapist though. If not, and they do have pain at rest or with motion, especially if they cannot bear weight and they cannot single leg stance on that same injured ankle, on the 5th or the 7th day, I proceed ahead and I do get a CT scan at that time. You might find this lateral talar process, you might find an anterior calcaneal beak, you might even find a missed 5th metatarsal, but you have to do it to see it. Or especially if they do not have pain, but they have pain, but it's still aching, it's not so apparent, then I might think about an OCD, a traumatic, and I would like to pick these up very early. So in these particular patients, and also if they're high professional athletes, and I'll show you in a while why, then I do ask for an MRI. So this is just the algorithm I abide by in the acute sprained ankle individuals that come in or walk into the ER. So just as a small conclusion to this part, if you have a sprained ankle, I would encourage certain criteria and would definitely discourage others. So I would definitely do the x-rays if, according to the Ottawa rules, there is a tenderness along these 4 or 5 points. I would discourage, especially in our country, it's very easy to get an MRI, and it sounds funny for a relatively poor country like ours, but MRIs are easy to have, and most of our junior colleagues would rather ask for an MRI thinking it shows more. In the acute sprains, in the bone bruises, in the bone edema, they might actually mask a fracture. So I think you have to abide by that. I would only cast for a few days, especially if they're grade 3. I would avoid prolonged immobilization. Also, some of our juniors are taught that they cast a patient and they tell them come back in 3 or 4 weeks, and I would definitely discourage that. I would actually have them definitely walking in after 5 to 7 days. I look back closely at their ankle and decide what I'm going to do next. If the patient has pain after the 5 or 7 days, and I can decide on a CT or MRI depending on how the ankle is going to sway me. And I would definitely not be swayed by the patient's pain or swelling or even insistence to be casted, because sometimes patients, they know that their next door neighbor had a sprain and they were casted for 3 to 4 weeks, and they probably are better off. I do not know, but I would not be swayed by the patient to cast them just because that's what they want. And I would definitely think more along the lines of functional rehabilitation with a close contact with the physiotherapy than doing or advocating surgical treatment for all. But is there a role for surgical repair in these acute ankle sprains? And this is also open for the floor, the participants, and for you, Luke. We might discuss about this. I kind of think that, yes, there is a very close subset of individuals. I think these young, and we can discuss how young is young or how old is old, professional or elite athletes, they want to get back earlier. And there has been studies that have shown that if you do attack these surgically, they kind of reduce to the 10 to 12 week barrier, which is almost the same as the physiotherapy, albeit you reduce the risk of their re-injury rates. If there is a definite combined ATFL CFL rupture, remember the MRI that we get at the 5th or the 7th day? If these show a complete tear of both, then I might be prone to attack these surgically. What we will discuss in a while is global instability. So if there's a lateral collateral ligament plus a deltoid injury, and if they are definitely unstable on my examination at the starting of the 2nd week, then I might think about doing these surgically. So I just want to remind you that this was a specialized edition of the Kester Journal. I was fortunate enough to be part of it. It came out in 2016, and the title of this special edition was "There is no simple ankle sprain. You have to look beyond that simple ankle sprain." So that's the part about the acute. Would there be questions? We wanted to try and make this as interactive as we could. Luke?
Okay, so thank you, Nassif. That was wonderful. And again, if anyone would like to send in any questions at this juncture right now, we'll do about a 5 to 7 or 8 minute Q&A right now. I don't see any questions yet, so I'll pose to you one, Nassif. So
Sure.
On that initial visit, when you're doing your Ottawa ankle rules and taking those x-rays, are you a proponent of gravity stress x-rays or gravity stress films, which gets chatted about in the literature quite a bit and at some meetings? Do you do that?
Yes, but that's if they do have this Weber C fracture, so this high supination external rotation injury. And I'm looking at that point in the ER if they do have an associated deltoid injury. So I would think about getting those as a second stage. So Ottawa ankle rules, they're tendon on the lateral malleolus. I do the x-ray. Lateral malleolus has this benign looking oblique fracture. Then I might add that gravity stress view, plus or minus the ecchymosis or the tenderness on the medial side. That would sway me if I would think more aggressively in those particular subset of patients.
Right. And then I understand that you discourage an MRI in the acute setting. At that 5 to 7 day, or let's say 7 to 10 day follow-up visit, how commonly are you getting an MRI at that juncture versus waiting, let's say, for a month?
Those that really push me to get an MRI, not necessarily verbally, I do not mean that the patient asks for the MRI, but are those patients that come walking in, but they still complain of pain, and it's usually pain at rest, this dull aching pain. So they say they can walk on the ankle, but they have a dull aching pain. So I'm thinking OCD, especially if it's going to be a traumatic one. I would want to pick those up early. And the second subset would be those high professional athletes or very vigorous athletes, because at that point in time, I would like to assess the ATFL and the CFL individually with the MRI, the swelling would have subsided a bit, and possibly the bone edema. I know it would still be there, but we have obviously excluded a fracture. So if there will be no fracture, I'm looking at the ligaments at that point to decide if I would go the surgical way or continue on the conservative functional therapy. If you're asking about numbers at the top of my head, I would say less than a third of these individuals will be getting an MRI.
Okay, wonderful. Now we do have a few questions coming in.
Sure.
So there's a question here by Khalid LCC. Excuse me if I'm mispronouncing the name.
Yeah, Khalid LCC. He's a good friend.
Do you differentiate between non-casting and weight-bearing is the question. So I guess perhaps are you recommending casting for that short time be non-weight-bearing? Or are you allowing weight-bearing? And do you
Yeah, if I understand the question correctly, is if the patient does in the end get a cast, would he weight bear in the cast? To be honest, I do not think it really matters, because at the end of the 7th day, I'm taking the cast off and I'm going to ask the patient to weight bear and look at how he weight bears and if there are any, is there any pain. Now, if he has been casted, that's probably going to be those with a more severe edema. They looked and felt unstable on my examination. They actually didn't want me to touch their ankle in the ER at that time, or the registrar couldn't really examine them. But I would be sure to take them off at the 7th to 10th day and then look closely at their ankle again. I hope that answered the question.
Okay, very good. Let's take two more questions here.
Sure.
And I think you've already discussed this, but Dr. Khalid asks as well, do you request CT scans or MRIs? Now, I think you've been fairly clear on that, but is there a case where you'd get a CT scan immediately?
I think if I fear that I am seeing something on the X-ray which is not there, meaning if I have a normal looking X-ray and the patient is exquisitely tender in a certain area, bony obviously, yes, I would advise a CT on the spot there. But the good side to these patients is that even if you do miss them, and let's say you've treated them, you've let them go away and you've treated them conservatively, you will get these patients back again. You have that safety net. You should be adamant. They will walk in again after 5 to 7 days. Edema and swelling has subsided markedly. You actually see the way the patient walks in to your office again. And if they still have that limp, then these are the patients that I would definitely ask for a CT, yes.
Okay, very good. And a little bit of a follow-up question to that real quickly would be, can pain without swelling suggest an OCD lesion rather than a ligamentous injury?
Yes, actually, I think that's very true, especially if there was a history of trauma. Now, we're talking here about that specific subset of traumatic OCD, which would, as we were historically taught, be more the laterals, and these are those that, yes, they're not degenerative, but they're the ones that you would want to pick up and fix, especially if you're going to use a bioabsorbable type of fixation. So yes, if the patient has had an acute ankle sprain within the last few days, he is weight-bearing, he does have dull aching night pain, he's walking into the clinic at that 5th, 7th, 10th day, he doesn't feel comfortable, there's discomfort, not that much swelling, I would definitely ask for an MRI and be looking for that OCD.
And final question, I think is a nice follow-up to what you just said, question from Dr. Mustafa. What makes you decide on putting on a cast after 5 or 6 days? Is it the amount of edema or the amount of pain expressed by the patient? So in your algorithm there, or more, in fact, your column of encourage versus discourage there, where you said you might cast at that 5 to 6, 7 day follow-up visit. Do you have a decision point there you'll say, I'm going to put them in a cast versus a boot or a functional bracing?
I think it's the ability to bear weight, excluding the fracture. So there's no fracture. The patient still has a significant amount of edema. I would cast him from the 5th to the 10th day, but then I am also, that's where I draw the second line. 10th day, you're walking into my clinic, we're removing that, and you're moving into functional rehab with motion.
Excellent. That's the key.
Yeah.
All right. Very good, Nassif. Wonderful. And thank everyone. Thank you to everybody for your questions. Let's proceed on with your second subset. I'll put my silence here.
All right. So, so these are the acute cases. Let's go on to the chronic cases. Now, what actually makes a patient move from the acute side to the chronic side? There are prognostic factors there. And this was a really nice paper by Doherty et al. In 2016. And I think the first two are concerning us as the physicians. If they walk in after 2 weeks, you're treating them as a first-time ankle sprain, and they cannot complete their jumping or landing or the physiotherapy. And this is why you have to be in close contact with your physio. It's not just sending them off and you lose all touch, all contact with them. If they cannot do that, and they're adamant that they cannot do that, then these patients you have to keep a close eye on, because they might end up with that chronic instability. And also here, even if they're progressing more or less nicely, up to the 8th week, the 2nd month of their sprain, if they still have a sensation of a mechanical instability, so they complain that they don't feel their ankle is really stable underneath them, or if you feel that there's an increased ligamentous laxity by examination, these are also a second subset of patients that I would keep a very close eye on, because I think they might develop into a chronic ankle instability. Now, number 2 and 3 are usually decided by the physios, where they think that they have these altered hip joint kinematics, or there's a deficiency in their dynamic posture control. So you always have to remember that to get a chronic ankle instability, once is enough. So if you've had only one single ankle sprain, that can develop into a chronic CAI. So one is the same as having 20. Each and every one of them, starting from the first, can result in a CAI. And the severity doesn't really affect this. So if you've had a grade 3 ankle sprain, doesn't mean you're more prone to develop a CAI than a grade 1 with absolutely no swelling. So we have to keep those in mind. And then there is this subset of patients where there's a mechanical and functional, and this was historically taught onto us, that there is this subset that you have to look for, and we all know the test with the eye closed about the functional instability. But I would like to draw our attention to this specific people, the group of patients. So you have the acute instability, you have the chronic ankle instabilities, and then we are going to discuss, remember, the global ankle instability in a while, so these patients here. But there's somewhere in between, there's this entity that has been now described, especially by Vega and colleagues, more and more, these micro instability. And I think this is a good part to put them into this talk. So remember this slide from the anatomy where we were historically taught that these two are one ligament, the ATFL. This is the CFL. Well, Vega, Mickey Dalmau, and colleagues, they believe that no, there are RC-form fibers that actually connect the ATFL to the CFL. And these RC-form fibers, they called the lateral fibulotalo-calcaneal ligament complex. And they believe, and they've shown these in biomechanical studies that, and in anatomical studies, that they're actually distinct into extra-articular and intra-articular. Now, the extra-articular groups are the classic ones, the inferior fascicle of the ATFL, the RC-form fibers, and the CFL, whereas the superior fascicle of the ATFL, and those of you that do a lot of scopes will kind of pick these up. These are intra-articular because you can actually see them from inside the ankle joint. And biomechanically, they have shown that in plantar flexion, that superior fascicle is tense, while in dorsiflexion, it's relaxed. So that also gives you an idea that these might be affected by that plantar flexion inversion injury. Now, the lateral fibulotalo-calcaneal ligament complex, the extra-articular, is tension throughout. And so this is courtesy, of course, of Vega. So how do I pick them up? I mean, how do I know that this patient has a microinstability? Because obviously he doesn't come in saying my ankle is giving way. If you examine these patients while they're sitting, so the knee is flexed at 45 degrees and 90 degrees, and the hip at 45 degrees. Vega described this test where you try and push your fibula backwards, and you have to always, of course, compare with the other side. Or you try and do this distraction with your thumbs, and you can pick up these. If you try it yourself, and you'll be amazed, you might be able to pick up these patients. And if you still have that clinical suspicion, you can go one step forward with an MRI. But in this case, it has to be an arthrography, so it's a little bit invasive. And the best cut to show that is the cut where you can see the PTFL clearly, and at that cut, you should consistently see the superior fascicle of the ATFL attaching to the fibula. So if it's not, then you know that you might have that. And at scope, if you've seen a lot of these normal lateral collateral ligament complexes, you will know that when you have this little bare area, that is probably not normal, and that there might be the superior fascicle of the ATFL, or part of your lateral ligament complex has been avulsed off or torn off that fibula. And of course, there are these patients that, this is not the subject of our talk today, but there are these patients that come and you see with that anterior osteophyte, whereas the thing that caused that anterior osteophyte is a traction on underneath the capsule, because there they have that micro instability, or that avulsion of your superior fascicle of the ATFL, and you can see that with a scope. And of course, you can proceed and you can actually repair that. It's basically, if you can do the scope and you know how to do it, it's basically very easy. Of course, a knotless anchor, you can debate whether you want to use the lasso or a mini scorpion. It depends on which part you want to pick up, and then of course using a knotless anchor to fix that and testing it at the same time. So there are these specific entities, these specific subset of individuals that might not complain of chronic instability, but they still don't feel their ankle is unstable, or they have these other pathognomonic signs as the anterior osteophytes, but that's also open to debate later on. So what about the main chronic ankle instability? Of course, they will have the main complaint as instabilities or giving of the ankle. They have difficulty in performing. They do, and this is also indicative, they do say that bracing or taping would help their activities, but they still don't feel their ankle is quite right. And we do know from literature that if you have a chronic lateral ankle instability, you can have a whole myriad of intra-articular problems. Some up to 97% will have impingements, endosmotic widening, OCD, osteophytes. So you're going to have a lot of problems by just that one major pathology would lead to different other pathologies. So you do have to pick them up, and you do have to know how to treat them. And before treating them, you have to make sure that they're not predisposed to a chronic ankle instability. So you have to look for these peekaboo signs from the front, the varus hindfoot, or the varus plafond. Of course, these predispose to laxity. You might even use Coleman block tests to exclude them from your diagnosis. And also now, this is coming up more and more in the last few years, this subset of subtalar instability. They do have difficulty on uneven ground. To be honest, I do not think that our diagnostic protocols in the present time are as good as they should be to pick up these. Perhaps that's a role for the future of the weight-bearing CTs and the cone beam CTs, but just as a main test, you can lock the ankle in dorsiflexion, so in 10 degrees of dorsiflexion. You try to adduct the foot, and then you might see this. If you get an x-ray at the same time, you might see this. Personally, I'm not very good at it, and I haven't seen a lot, but that kind of makes me look out for the CFL, and I'll show you in a while. Of course, you can use any type of radiology to look for other occult lesions, like we said, especially the MRI. You are going to be using them anyway to completely diagnose these CAI individuals, chronic ankle instability, but you should use them to exclude other causes such as peroneal tendon or fractures or OCTs. So intraoperatively, of course, the anterior drawer test is the most significant clinical test you can do, especially like here, if it's under anesthesia, and it shows that dimple sign. But also you can do the talar tilt test. This is Jorge Batista's hands. He sent me this video. It's real nice, and it's showing the talar tilt. That gives you an idea that you might have an associated CFL, obviously. Well, basically, radiologically, you can use a whole different armamentarium to try and pick these up, but we all know that each and every one of these is less than 60 to 70% specificity and sensitivity at picking them up. So personally, I did rely on the sensation of instability of the patient, the clinical tests, secondly, and the MRI. And I really like the axial proton density fat suppression imaging, because it actually shows you that ligament. If you take consistently this cut where you can see the talar neck starting to form, in that cross section you can see a normal ATFL, an attenuated CFL or a completely torn ATFL. So I think the axial proton density fat suppression imaging is really good. Of course, you can also use arthroscopy, especially if you're thinking of an arthroscopic repair or you want to exclude other intra-articular pathologies that you think the MRI might have missed. And I think this is a good part to show these specific subset of people, the global instability. Why? Because these are patients that have lateral to lateral ligament chronic ankle instability, but you add in a deltoid and they get into global instability. And this has been recently described also by Vega et al. This is a normal deltoid. So this is the medial malleus, and you can see the tenacity of the fibers on the medial side. They're clinging onto the medial malleus there, and you can actually see the fibers, no synovitis, and they are really adherent to the deltoid. Whereas if you look, if you have a scope and you're looking at the medial side, and you can see that that's not normal. So there is a part of the deltoid that has been taken. Remember, this is a patient that has a CAI. That patient was scheduled for an operative treatment of the lateral side for the chronic ankle instability. Another case here, you can see we're scoping in from lateral to medial, and that's even more obvious. You can see the whole deltoid is avulsed off. So this is a rotational instability that we need to consider. These occur only in 10% as far as we know from literature, but you should not miss these. You should not miss these, so keep those in mind. So moving on, is there a place for functional rehab as opposed to the acute in these chronic? Of course not. In a Cochrane review, yes, it was almost 10 years ago, but there is no data to support non-surgical treatment, although you do have to give them at least 3 months of conservative trials on muscular training. So which patients am I going to operate upon? Of course, those that have chronic symptomatic mechanical instability, those who have failed the conservative treatment for more than 3 months or at least 3 months. And the patients I would not operate upon, even if they do have CAIs, are those with peripheral neuropathy, peripheral vascular disease. Now, classically, we were also taught those that do not have a sensation of instability. Now, I don't know, maybe I'm picking up more cases or I'm getting referred more cases, but I'm starting to see patients that they just do not know how to express instability. And more often than not, I'm referred patients that just have pain in the ankle, chronic pain, and their activity, they're a banker, they just go to the club and they walk a few rounds on a track. Their activity level is not that much, but they just have this pain, and it's almost due to this instability. So this for me is a relative contraindication. We can discuss that later on. We all know that to treat these CAIs, there have been almost 100 procedures. They are mainly grouped into anatomical and non-anatomical. Of course, literature has shown that if you can repair them anatomical, it's much better. And now the gold standard, of course, is a Brostrom repair. It's been that way since 1966. And personally, I thought that, Brostrom's, it's a wonderful operation. I do it. All my patients are almost always good, and they're just fine. So it doesn't need any augmentation. But we do know that these are chronic ankle instability patients. So what you're repairing is actually the remnants of the tissue, especially if the patient has had more than one episode, or they have this feeling of giving way, or if the patient has a ligamentous laxity, and we can discuss these subset of patients later on. Almost ever since 1966, there has been a need to augment the repair. So Brostrom originally described the Brostrom, just attacking the ATFL, but then you had the Gould, the Carlson modification, XYZ. You have a lot of modifications because they just felt maybe the Brostrom is not enough. And as we said, if you do a Brostrom and you do it classically, you have these drill holes that are holding sutures from the ligament into the bone. But then you would want to cast these patients. And if you cast these patients, you would want them to be immobilized for them to heal adequately. And that goes against just what we just said, that mobilization is better for these patients. And as we said, there's a questionable soft tissue that is removed. And even if you do, and in my personal series, I have had failures with what I thought was an otherwise very adequately performed rostrum. But some of these patients, up to a quarter of them, might fail. And ever since Mafuli in 2013 questioned, do these patients actually return back to their pre-injury level? Especially if you're dealing with athletes, even not the professionals, just these everyday or these weekend warriors or these 3 times a day triathlon athletes, do they actually return back after doing the rostrum to where they were before they had that initial sprain that led to the CAI? And as we know, this injury is very, very common in otherwise these high-performance athletes, and they're always being pushed by the coaches, by the trainers, by their physiotherapists, by themselves. They have these huge mega-sum contracts, and they want to get back to their field much earlier. So we should question these. Luke, let's take a break here. Try and make it interactive.
Oh, okay, very good. Thank you. Let me turn my camera back on here. So wonderful. There have been a few questions that have come in. There's one that we'll save for a little bit later at the end. But you've talked about the deltoid involvement. You did talk about the 10%, but perhaps even within these chronic ones. So do you routinely scope all your chronic ankles then? And then a follow-up question from Dr. Mustafa regarding, let's just say, arthroscopic repair of the ATFL being as effective as an open rostrum without adding the Gould modification. So do you scope all ankles? And then what's your feeling on arthroscopic repair, rostrum versus open rostrum?
Okay, that's a great question, because those who do the scopes, they know that if you're going to scope an ankle before doing the open rostrum, you have to be very quick. There has to be certain criteria. You have to extravasate the limb. You have to really compress it. I personally use elastoplast and do the portals through the elastoplast bandaging. And I do not use water pump at all, because there is a tendency that lateral collateral ligament is already gone or is redundant or is not adequate. So there will be a tendency for extravasation. And then if you take the scope out and then you try and do a repair, you would have this soggy material to work with, which would not be very good except if you have done a lot of these. So scoping a patient that I am going to open later on has certain precautions. Now, to answer the question more specifically, would I scope a patient whom I am planning to treat, let's just say open, with a rostrum? Yes, especially if I feel that the patient has certain, in his history, there's a dull aching pain that's not consistent. The MRI, I have an area which I do not feel looks really right. I would scope these patients preliminary before doing it open. I would specifically scope them to look at the medial side and the deltoid, because these injuries I showed on the scope, they are very rarely, if ever, picked up with the MRI, because you have to have a certain cut, and sometimes, as you saw, they are actually partially avulsed. But on the other side, the flip side of that is these rotationally unstable patients, they are markedly unstable. So they come in with a completely unstable ankle, and you can feel the patient has medial and lateral instability. The second part of the question is arthroscopic treatment. Yes, I am shifting now more and more towards arthroscopic rostrums. We do not yet have a prospective, up to my knowledge, a prospective randomized control subset or paper that prospectively is treating patients arthroscopically and open, not to my knowledge, but retrospectively, there are a horde of papers, especially in the last 5 years, that have shown that the results are nearly as equal to the open as the arthroscopic. So short answer would be, I would scope a patient, especially if I'm going to do it arthroscopically, so I would obviously be starting with the scope. If I'm going to do the patient open, then I would scope very quickly and specifically to exclude the deltoid side if the patient's symptoms are not so obvious. I hope that answered the question.
No, that's wonderful. Thank you. I'm going to follow up with that by combining a question from Dr. Ahab and Dr. Scher, and that is one part A is, so to speak, indications for deltoid exploration, which I think you've basically covered, but indications for deltoid exploration with these chronic ankle instability cases, and also, if diagnosed, do you always approach it surgically, or will you perhaps modify your postoperative management? Let's say immobilize longer or something like that. So is it always a surgical option for that once you've identified it? And it sounds to me like you're looking for it on every case since you're scoping first, right?
Yes, especially if the patient walks in with this profound instability. These other subset of patients that have pain, they say, my ankle doesn't feel right. I feel I'm not so comfortable in certain shoes, in certain areas, walking on gravel, on the beach, on sand. These do not have that global instability. So I might be less prone to look on the deltoid, although if I am using the scope, I will definitely look. I mean, I'm there anyway. Now, the second part of the question is, if I do find them and repair them, it would differ in the protocol if I was only doing what I was doing 7 years ago, just a modified Brostrom or a Brostrom Gould, because then I would have costed the patient more, because I would not be sure that on lateral and medial side that I can allow the patient to bear weight or mobilize them as much as I could, even though I know that would be good for their tissue healing. And this is where this third and last part of the coming up lecture is good, is that I'm now using almost internal bracing and this augmentation for almost every patient that I would attack laterally. And that gives me the confidence on the lateral side that they would be fairly stable, so I can mobilize them with the medial side, if you will, for lack of a better word, more physiotherapy oriented, with less immobilization, because I have that safety belt on the lateral side. I don't know if that answered the question.
No, that's excellent. Thank you. Now, there's a few more questions, and I'm going to leave them for after your next subset, but I have one quick one myself, and I'm just curious on your thoughts. So why is peripheral neuropathy a contraindication to surgical chronic ankle instability? I'm just curious. Is it because we don't think that they feel anything?
I knew you would get me, Luke, on that one. When I put up a relative contraindication, this is classic teaching, and we have to bear in mind that we are also talking to juniors, mid-levels, and even seniors or experienced guys like you. That has kind of fallen back to the same subset of the pain-only individuals, because I do not think that peripheral neuropathy is a complete contraindication, because peripheral neuropathy then encompasses everything from a diabetic, 2-filament tests patient to a neurological disease. Now, my guess on that, or where I would draw the line on that, is if that peripheral neuropathy, the monofilament test, the sensation is absolutely, and there are these, how do you call it, the classification scoring systems for these patients. So that's on the diabetic side. If they fall, I think the number was 6, I'm not so sure now, then I would not want to touch them because of their rehab, and because they can wear it out without feeling that alarm of pain to stop them during the healing. And this is also where the brace might come in handy. Now, if they have crossed the line, or if they are peripheral neuropathies because of other neuromuscular diseases, if these patients have a cavus foot, a cavovarus foot, blah, 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 then I would treat that condition first and not simultaneously, providing that their neurologist has given me the green light that this is not going to progress further. So that's just my take on that point. I'd love to hear you say.
Yeah, I think it's a very interesting debate, and beyond the parameters of what we're going to talk about today as far as time considerations, but just a thought, and then we'll move on, is that I've treated so many Charcot patients in my career that I always reflect on what Dr. Paul Brand always said, I'm pretty sure he gets credit for the line that pain is a gift. Yeah. And it's these insensate patients that I think actually are at a higher risk for going on to Charcot dislocations of the ankle and perhaps the midfoot. And so, you know, a chronic ankle instability case in an insensate patient who it's a functional issue and it's altering their gait and they may be at a risk for a Charcot progression. I agree it's a relative contraindication, but those are patients that would get assessed very carefully in my own hands to be sure that we couldn't be helping avoid a kind of more catastrophic event down the road, if you follow me.
Absolutely.
So, okay, wonderful. So let's proceed with your next subset. I'll turn myself off here.
Thanks, Luke. I hope you guys are not bored out of your wits, but this is the last subset, I promise. So as we just said, this discussion, this is why I'm moving more and more now towards this internal brace, because it gives me that stability that I'm looking for. And it also crosses the bridge between me doing a good repair, at least I think I'm doing a good repair, but I want to mobilize these patients as quickly and as adequately as I want to get that good healing response. Because the operation doesn't end on the operating table, it actually starts there, your rehab. So what I think is good, the positive points about it, is that it's truly anatomic because it's put extracapsular in and along the lines of the ATFL. It protects your repair, so you have to do an adequate rostrum. It is not a substitute for your rostrum, your adequately done rostrum, but it is actually a safety belt allowing it to heal without any undue strain when you're trying to mobilize these patients as quickly and as rapidly as you want to. And I think it gives us consistent results, whatever the condition of the attenuation of the original ligament and capsule are. So if I have less amount of tissue to work with, I can still augment that extracapsularly by the brace itself. And that confidence that it places allows me to accelerate this rehab and reduce the time away from sporting activities. And of course, this is, I think, for me, and at least in our country, is that it reduces markedly the re-rupture rates or the recurrence rates of these laxity and patients. And of course, you can also use them in these ligamentous laxity patients. And it's not a new concept. I mean, at least more than 1.5 million fiber tapes have been implanted all over in different areas in the body, shoulders, knees, you name it, elbows, internal and external even, to the joints. And in braces themselves in ankle, and these numbers, of course, are from last year, so I think even 2 years ago, so they've even increased more. And biomechanically, and this was way back in 2014, it has been shown that if you have a rostrum with an internal brace, it's almost twice the native ATFL, or if you're using anchors alone. So I think there's an evolution from just repairing the rostrum using drill holes in the fibula, then anchors, and then using it or augmenting it with a brace. So it's a kind of evolution of reparative methods, if you would like. So what is the brace? It's a fiber tape as opposed to a fiber wire. It's an ultra high strength 2 millimeter wide tape, so it's the same tissue with the same polyethylene structure as the fiber wire. And of course, being a tape, it reduces the notching. And it has been, as we said, widely used all over the body. And it comes either singly or as, and remember this slide from the acute, even more so in the chronic, because of the same idea that you need to mobilize that ankle as much as you can, as early as you can, in spite of having done the repair. And what's also nice is that the swivel locks, they are fenestrated, so they allow for the tissues to the blood to pass in, especially if you're using these peak ends, and this allows the healing to occur as near anatomical as you would like. This is a case, I actually picked up this case because of the methods of fixation. You can discuss about the incision. I like to see the perineal tendons just so that I know I'm doing a good repair. I separate the anchor, so this is an Arthrex 2.8 suture tack. I drill the fibula, but I also place the fiber, the swivel lock on the talus first, remember, and then I pass the tape extra articular to the repair, to what I'm going to repair. I still haven't done the rostrum, as you can see. Now I'm doing the rostrum with what's remaining of the tissue. And as you can see, pants over vest manner, whatever method, I have already denuded that part of the bone. And sorry about that. And not my surgical cap, sorry. Anyway, and then in that particular instant, I didn't have except the 4.75 also swivel lock for the brace on the fibula, but I also used it. At that time, we had run out of the 3.5. And as you can see, that's the brace. So I picked up this particular case because you can actually see where the implants are. And you can actually tell, as opposed to, of course, using the peak part. But of course, they're better if you have them. So just a few technical points, and when you're doing this operation open, obviously, is that you should make the entry points of your fibular anchors, your suture tacks, or whatever you'll be using, as wide apart as you can to allow for the later introduction of your swivel lock for the limb of the brace that will be inserted into the fibula. Of course, you can replace your suture anchors with also drill holes. At that point, you should also be sure that you can see the posterior margin of your fibula. I personally think, and there are a lot of debates about this, that I can drill the talus first. It's easier. But what I do is I always make sure that I have the insertion point of the ATFL intact on the talar side. And maybe that's why, since I'm there, I also drill the talus first. And of course, you should drill it almost parallel to the foot, so you avoid entry into the subtalar joint. Of course, with time, I rarely, if ever, use a C-arm now with that, because it's I mean, the talus is right there, and you can actually see it. But of course, if you're starting out, you better use the C-arm just to navigate with your position. In addition, now I repair the rostrum normally in complete dorsiflexion and in inversion. Now I want that tissue as tight as possible. But in contrast, when I put the brace in, I want it lax except in inversion. Remember, it's a safety belt. It does not replace your rostrum. So I actually plantarflex or neutral, put the ankle in neutral. If I have a bump underneath the foot, at that point I take it out because it inadvertently takes the talus and the foot anterior, and that makes my repair more lax. And then I actually put a hemostat underneath it when I am inserting the fibula, because I started with the talus, and then I am doing the tension, the last part of the tension on the fibula. You can do it vice versa if you want, but in either with the talus first or with the fibula first, I also advocate putting this hemostat to keep that brace as lax as need be, because I think one of the worst things you can do is over-tighten that. And this is why I perform it in neutral, or very minimal eversion, in fact. And that's where I alluded to this posterior bumps underneath the foot. And that will be the final shape of the construct. And of course, avoid over-tensioning. Now, this is the classic rehab. So if you've done a rostrum, you would, this is what you would be thinking of doing. 3 months plus 3 months, and return to sports not before 6 months. You might allow immediate weight bearing, but protect it at that point. Now, this is the rehab that we've been doing for these internal brace patients. Now, this is one of our national basketball players, and he's in my downtown clinic, and you can see he's doing single leg hops, and this is 6 weeks. And I had a hard time convincing him and his physiotherapist, because we had I think it was at that time the Arab League champions coming up, that no, you still have to wait a while. You feel good, but you can't just jump into competitive sports right now. Although I do know that some surgeons, and Gordon McKay has pictures of people doing snowboarding, I think, at 10 weeks. So it does allow you that safety belt. It does allow you that faster rehab. But I think even more importantly is not these highly trained or professional athletes, is the simple layman, the simple banker, the simple individual who doesn't do a lot of sports, it prevents the re-rupture rates. And this, for me, is, I think, one of the most important points. Also, we do not have still now prospective randomized trials, but there are a lot of good papers. This is by Chris Coetzee and company. He showed retrospectively that patients with open rostrum and ligament augmentation with the internal brace do markedly well and even better than the subset of those that have just had the rostrums. I do know that Anand Vora, good friend of yours, Luke, he has started off a prospective randomized trial with patients, so one subset without the brace and one with, and prospectively looking into these. I think those results might be out next year or so. So that's something to look forward to. Anyway, in conclusion, with the chronic ankle instability, I think most patients might do well, especially if they're not high athletes with rehab for 3 months. We should think about this functional instability, micro instability, and I will add global instability. Your clinical tests can be falsely negative. We do know that they do have a 60 to 70% of specificity and sensitivity. Yes, you should get your MRIs, but they can miss intra-articular cartilage chondral lesions. So we have to keep that in mind. Examination under anesthesia, in my hands, is a very powerful tool, and I routinely do that for each and every individual. And I actually get a fluoroscopic shot of these patients preoperatively because they usually have a non-significant stress view. So I get these intraoperatively before I even touch the scalpel. But of course, arthroscopy is an even more powerful tool. As we said, and we discussed, the deltoid and syndesmotic injuries are one of the most important causes of instability, in addition, especially with fractures or with CAIs, and they are often underdiagnosed. Maybe, if the patient has just instability, the MRIs are conclusively negative, I might not do the arthroscopy. This is an answer to the question, do I always do an arthroscopy? I will just add to this point here, especially if I'm going to do the patient just open. I might not put a scope in, although, to be honest, this subset of patients is markedly reduced over time. I now have a very low threshold for scoping a patient before doing the repair. You should always look for CFL injury. It will change your course, although there are now recent papers that, remember the fibulocalcaneal ligament, that arsenate fibers, there are papers that are showing that if you only do the ATFL repair, you might actually pull up the CFL in addition. We still haven't biomechanically proven that one way or the other. I am sure that internal brace patients, they rehab much, much faster. What's even more important, their re-rupture rates are almost negligible. And if a patient is walking in with a failed rostrum from myself or from other colleagues or from other, they do not get a re-rostrum. I have to augment that either with the amount of tissue that's there, or I try to do an anatomical reconstruction using, we do not have allografts where I come from, so using a semi-T or a grafts. Acute injuries in high-performance athletes, these might need faster rehab, and these might be just that subset of patients that would get an acute repair, and I'm talking now about acute ankle sprains. For myself, almost now in almost all cases, I use a brace when I'm doing or tackling surgically CAI, even if arthroscopically, and you can do it, it's very easy. Except perhaps in these very young girls that have these very, very small feet where the surface area is not too much to accommodate swivel lock, even if it's a 3.5, and 2 suture anchors or drill holes in that small fibula. So I think that's the end of that talk. Thankfully for you guys. So.
Thank you, Nassif. So yes, there's a few questions, and I'd like to combine a question by Dr. Kinner, which was regarding the postoperative regimen of the rostrum, which you've covered there, and also a question by Dr. Darren Bruce, which is that regarding pain and stiffness after the rostrum Gould plus internal brace, at what point postoperatively can the patient start feeling that the tissue is well healed enough to, start feeling more comfortable. So you've covered your rehab protocol, but in the spirit of these two doctors' questions, could you just summarize perhaps the difference, kind of the bullet point again, between your previous rehab protocol and now your current protocol with internal brace? What's the real advancement point? And then if someone is complaining of pain and stiffness and so forth, how are you reassuring them it's time to get moving? Do you have an objective test or criteria in concert with your physical therapist, perhaps?
Sure. To cover the first part of the question is, when I used to do the brostrums, classically I was taught that they have a 6 weeks period of at least non-weight bearing. They're mostly put in a cast or an air walker, if you will. And what they can do is just range of motion exercises, usually after their stitches get taken off at the 2nd week to the 4th week. And they do that non-weight bearing. And when they finish those 6 weeks, then they start moving on to from passive to more or less active rehab with their physio, with strains, isometric type of exercises, and they don't start with their proprioceptives, I think, before the 8th to 9th week, or 10th week, which is 2.5 months down the line. Now, if you put the brace in, I don't cast them. I actually just have a bandage, and I actually allow them, just because of the tissue healing, I do quiet them down for the first 2 weeks till the stitches, if I've done it open or even arthroscopic and they're not absorbable sutures. I have them doing that range of motion immediately from day one. Also, I have them walking in a boot from day 1 to 2. So, but the boot is more or less for the soft tissue healing of the skin, all right? Mm-hmm. Now, they start immediately with their physios, with tone. You'd be surprised when you do a lot of these, you'd be surprised that they're the ones that are pushing their physios. Doc, I feel fine. I want to move on forward. No, I've been doing this for 3 days now. Let's move on. I want to do this next thing.
That's right. Gordon McKay always makes a nice point of that as well. And
it's true.
He's the most experienced just by time and years of experience, right?
Yeah, he has much more experience, of course, and in other parts of the body, the knee, and he's seen this. I think it's been, to be honest, it's a game changer. And I have had more and more calls back from physios that, Doc, Nassif, is it okay that, this patient, he wants to move on to my balancing board now? I know it's only 10 to 12 days, but is it okay? Is there anything wrong? Will I be jeopardizing your repair? And so on and so forth, because they're being pushed by the patients themselves. The other point is about the timing. I'm not sure I have a definite answer for you. Is when do I think that they could move on to the field? I think that was your question.
Well, let me interject there. So the question was in regards to pain and stiffness after a Brostrom Gould plus internal brace. At what point post-op do you start feeling that the tissue is well healed?
You see, that's also, I think, I know I keep advocate. I'm a huge advocate of it just because I have tried it and I do know that it does work. But you see, that's also another thing, as opposed to the 6 weeks you have in a cast. These patients almost always, my patients, they almost always, previous Brostroms only, they almost always had pain and stiffness because you're moving them out of the boot or the cast after the 6 week or the 1 month time. And they're stiff. They can't get their motion back. So the physios spend at least another 2 to 3 weeks, half the time of immobilization, to get them back to the range of motion. Then they start with their isotonic, isometric exercises. But because these internal brace augmented patients are mobilizing from day one, I have almost never seen a case of stiffness. I will say something also, that I have had to go back in a certain patient, wasn't a patient of mine, that was done with internal brace, and I think that the preceding surgeon missed the concept because that patient could not get inversion at all. And I had to cut off the brace. That's all I did. Small incision, I cut off the brace. So they had put it in severe restriction. That's when you can get your pain and stiffness. And that patient was absolutely fine later on, although I did this at the second month, so it was week 9, and he was getting nowhere on his physio. He couldn't actually even walk properly because obviously you had restricted his ankle dorsiflexion motion. So you can imagine that there was no walking. And then we had to go slow on him because we had room, but it gave him that protection for those 6 weeks, which I think did him good, at least ultimately. So pain and stiffness after the augmentation, I think it might be due to a technical error rather than a case. Of course, you can't just throw this out in the open for every single individual, every single case. Last point is the when do I feel that the patient is good to go? I do take my green light back from the physio because they are more into, especially if it's an athlete, when this patient is feasible by their parameters to go back. But what I do is I actually stress out the ligament in plantar flexion at the 8th to 9th week visit, which is when I see them again. And if they have absolutely no pain, the range of motion is complete. I have them do these single cross figure, figure of 8 jumps, like you saw that. Sure. Yes, that professional basketball player. If they can do it with complete confidence, then I tell them, okay, you go back to your physio and coach and team and see when they want you. They get on the bench, but not necessarily active participation.
Thank you. So another question here, a few more. Let's combine one. Dr. Salim asks, how frequently do you repair the calcaneofibular ligament plus the ATFL? And I'll ask you at the same time, have you ever reached up with a branch and reinforced the anterior inferior tib-fib ligament? So CFL plus AITFL.
Okay, that's also an awesome question, of course, which I don't think I will answer particularly well, but I will try. CFL, I think less than 30% of cases. And if I do feel the patient has in addition to the CFL, these are the patients that I would definitely look on the medial side, and I'm fearful of this global instability. And in that particular situation, yes, I would extend the incision just a little bit. I would do the calcaneal insertion point percutaneous, but I make sure that I take it below the peroneal tendons.
Sure.
Not above. Yes, and these patients are those with those instability, and if I can see, you remember that intraoperative under anesthesia examination that I do? Yes, with the C-arm. I do it on both sides. So I take the other side as a landmark. And if I see more instability, whether it's on the ankle itself or now that's where I do the subtalar, then I do reinforce the CFL. The other part is about the TIFL. I do know that there are people, surgeons, even Jordy himself, he actually takes the ATIFL and takes it to replace I've never done that, and I particularly, and this is where we kind of argue about, me and Jordy about that, but I do not think you can do that with that ligament. There is no play within the ligament.
He takes the anterior inferior tip of the ligament and rotates it down?
Yes, and rotates it down to insert it on the talus to replace the superior fascicle of, he's a great guy. He's a genius and with a scope. He's miles ahead of me, so I can't argue with him. But I don't think.
But is he sacrificing a component of syndesmotic stability to stabilize the ankle?
This is a discussion that we can really get lost in. But he's a proponent of the inferior basset ligament and the yes, these subset of great surgeons that do not really think that ligament contributes much to stability. Remember the anterior impingement? Yeah.
It's actually maybe more problematic because it could be impinging on the lateral shoulder of the talus. That when Bassett's is kind of an extension of the anterior inferior tib fib anyway.
I just mentioned this in just to show that there are surgeons that even go more drastic to that. Now, in return to your question, do I reinforce the ATIFL? Yes, if doing the scope, I can see there's that starting of syndesmotic instability, and I can introduce that 2.7 shaver right into the syndesmosis, but not quite enough. Then I can reinforce that because I'm there. It's there. I'm open or arthroscopic. It's almost a percutaneous procedure, and you don't need much. The only downside to that, of course, is that you do need an additional smaller swivel lock to insert the brace you're doing. There are people I know of that actually run. They have allograft. They have access to allograft. As I said, in our country, you don't. So they do have a gracilis or a plantaris, which they run through, as opposed to using a brace. But I think if you're doing the ATFL, you have both limbs of the brace there. I might as well use one limb for the ATFL. But again, I would be sure not to really compress that.
Very good. Thank you. I'm good. We have two more questions that I'm going to combine from our colleagues. And one was about if you do suspect subtalar joint instability, what do you do? And also, well, another question just came in, so let me combine that. Have you ever encountered a patient who was both having CFL, ATFL tear, and subtalar joint instability? So the question is, if you suspect subtalar joint instability, how are you dealing with it? And before you answer, I want to share what I always remember, because perhaps it'll help because you're such a skilled arthroscopist. I can never forget the article by Carol Frey from Los Angeles, and I think it was probably 20 years ago now, perhaps. And she really demonstrated in that article that subtalar joint instability was more of a translational anterior-posterior instability that was being picked up well on that movement under a scope shot versus, the frontal plane inversion, eversion instability. So I was always kind of fascinated by that. So what's your overall feelings, Nassif, on subtalar joint instability and how you either do recognize it, which you did talk about some, or have you addressed any surgically yourself?
To be perfectly honest, I think there is an overlap between CFL and subtalar instability. I do know that there are people that are proponents that the actual subtalar ligaments are lax or are torn, and that in itself, and I think that's what Frey was alluding to when she was describing the anterior-posterior as opposed to the eversion motion.
Yes, now, that can only be the interosseous ligament, really, interosseous cervical ligament.
Yes. Now, what I can say is I have not seen patients that and this might just be my misgiving, that just come in with the subtalar instability and need that to be addressed. But again, having said that, I'm sure I'm missing a lot. What I do know, and this is also from literature, is that we do not as yet have an exact mechanism or a protocol of picking up these patients. And I think, as I said in my talk, maybe I just said it in a few seconds, is that we might, that's where the weight-bearing CT or the dynamic CT might play a role. If I do find that the patient has an excessive subtalar opening, but in this case it's an inversion, so I think that the talus is tilting, but I can also, while trying to immobilize the talus in dorsiflexion, that I can also see the subtalar opening in inversion. Now this is not the AP. Then I would these are the patients that I would augment the CFL with. So I would take the CFL component of the repair and use that to treat the subtalar instability, if you will. But I do not have much experience on that, and I cannot answer you fully till now.
Well, thank you so much. And I'll just add to this, my own response to this question by Dr. Lacorda, who did ask about the subtalar joint instability. And my experience, again, I don't have any sort of great diagnostic test either, but I've always used the Gould modification of the rostrum to really give some subtalar joint stability, because the origin of the extensor retinaculum is off of the floor of the sinus tarsi. And so you're really traversing or bridging the subtalar joint with the Gould retinacular reefing of the rostrum Gould. And I have always found that, again, this is not scientific, but I, for many years, operated on the military in eastern North Carolina in the United States. I was the dumping ground, so to speak, for 3 different military bases. And the young soldiers were coming back from Iraq, the Iraqi war, believe it or not, back then. And, they were incompletely rehabilitated ankle injuries. They were not getting completely well. They were being redeployed. And a lot of them just had this kind of global ankle subtalar joint instability subjectively on my part. And they all did very, very well with rostrum Goulds. This was pre-internal bracing. But anyway, that would be my contribution to answer that question as well, that the Gould modification, I think, really does add a component of subtalar joint instability.
Yeah, that's a wonderful.
Yeah, it's just been my experience. Now, Dr. Kajal asked, and this is a great question, going toward an hour and a half here, so perhaps we'll kind of wrap up with this. And I have one other, and then we'll see what Mike, how we all think. But Dr. Kajal wonders, can subluxing perineals mimic chronic ankle instability? So have you had a case where a chronically subluxing perineal tendons, perhaps a torn superior perineal retinaculum, has mimicked some of the symptoms of a chronic ankle instability, or have you seen them together, or do you have a comment on how you treat? We don't need to go into, I don't think, a whole lecture on subluxing perineals, but certainly lateral ankle perineal tendon pathology, longitudinal tears of the perineal.
Yes. You can get strains and stresses on the perineals in patients with lateral ankle instability, obviously chronic cases. I have not seen a patient that mimic, a perineal subluxation as opposed to a subtalar, as opposed to a chronic ankle instability. What I do know is that these patients who have perineal subluxation, they do also have a sensation of instability when that perineal locks out of their groove. But you can easily, you should easily be able to identify these clinically. And obviously, if you diagnose them and they are not rehabilitated and you're going to go to surgery, your incision and your treatment protocol is going to be different. Mm-hmm. Having said that, as I showed in the case, I routinely just take my incision just a little bit more posterior. Now, this is coming in from my rostrum days, where right. I used to go with drill holes to the posterior fibula. So I wanted to suture on the posterior side of the fibula these drill holes for the sutures of the rostrum repair. And that automatically allows me to look at the perineals. If they're glistening white, they're fine, they don't have these longitudinal tears, then that's it for me. I still do incorporate that. It does take the incision a bit more, but it kind of gives me that safety that I do know that I've seen the perineals. But no, I have not seen a case where I have had perineal subluxations chronic with a chronic ankle instability. Have you, Luke?
No, I haven't. And I think actually I think it's a great thing to think about. I think it's a wonderful question, but I think the mechanics of getting one versus the other are
different. Yeah.
Different.
Yeah.
However, the perineal tendon, the recognition of perineal tendon pathology in concert with lateral ankle instability is hugely important.
Yes.
And I always like to think of it as the step brother or stepsister, so to speak, of posterior tibial tendon insufficiency and even spring ligament pathology. So I've always thought that we probably under-respect the amount of lateral compartment, peroneus brevis, peroneus longus tendon pathology with lateral ankle issues. And we kind of give all the love to the squared flat foot and the posterior tibial tendon and the spring ligament. But really, when you think about it, it's the same in reverse, and I think worthy of the same considerations, particularly in trying to stabilize these patients and discourage recurrence. So if someone has insufficient peroneal tendons, and for whatever reason, longitudinal tear, split tear, accessory muscle, something, and we're doing a Brostrom Gould internal brace, whatever, we're getting wonderful ankle stability, but maybe their lateral muscular compartment is just not, fully functional. What are we doing to improve that? In other words, how are we leaving the situation mechanically, biomechanically better than it was going in? So I think we always need to be sure we're not just focusing on the lateral ligaments of the ankle, but we're focusing on what I always call in my flat foot talks, the muscular pulleys, the muscular compartments, and so forth. So I have one kind of wrap-up question, I think, and I just was interested in an article that came out in the Journal of Foot and Ankle Surgery 2019, just very recently, and it was comparing the amount of anterior ankle impingement found with chronic ankle instability cases, and it made a summary that really sort of echoed what Dr. Neary's publication he had put out spoke of, and that was that the results of chronic ankle instability surgery seem to be a bit poorer in those patients who've also had a bit of anterior ankle joint impingement, more, let's say, an osteophyte or something. And since you are such a skilled arthroscopist, I'm just wondering, in your own patient base, have you seen the same thing? So the literature seems to be suggesting, anterior ankle impingement with chronic ankle instability, these folks are in general doing a little poorer than those who don't have it. But I'm sure, we're still going to be stabilizing them. But is that affecting your preoperative conversations, your coaching of expectations, and so forth?
Okay, that's actually a very, very, of course, it's a wonderful question, and I'll tell you why. Because I think this subset of patients are very specific, and there are studies now that are looking into actually the type and location of the osteophytes. Now, if you have the generalized anterior lipping more on the lateral side, as opposed to those parrot beaking osteophytes, there has been a discrepancy, and it has been shown that these parrot beaking osteophytes, the ones where the anterior tibia, especially on the lateral side, is more is actually sharp. And we do know from arthroscopic views that these are not traction spurs, right? And I think this has been a whole workup, especially with Vega and co-workers, that they are actually driving that into the micro instability factor. So they are thinking that micro instability is causing that abnormal motion between the tibia and the tailbone.
Okay.
And is causing. And this might explain the poorer results. That there is another... Yes, that there is another pathology, if you will, that is playing a role in that particular patient. Now, the other subset of osteophytes is those that are on the medial side, that have the kissing lesions, that are chondral lesions. And these patients, I think, if you see a patient that has an abnormally located osteophyte, and especially if the talus on the MRI, remember these are also chronic ankle instability patients that you probably would have gotten an MRI, or you have a feeling of their instability. Now, these patients are those that I would definitely urge the surgeon to look on the deltoid, because you might find that deltoid is just like I showed, has that little avulsion off that side, and that would explain that minimal rotation of the talus in the mortise causing that osteophyte medially. So in a nutshell, and this is all not yet scientifically 100% proven without a doubt. It's a feeling you get from looking through a lot of cases arthroscopically and a lot of failures. If the osteophyte is on the lateral side, more parrot beak, more sharp, demarcated laterally, you should think about micro instability, even if the patient does not complain of instability. If they are on the medial side, larger, with chondral lesions, abrasions, look on the medial side, look at the deltoid, you might have a component of rotatory instability. And both these factors would obviously give you lesser improvement if you just tackle the lateral side.
Those are excellent points, Nassif. Those are really wonderful points. I think that we're at over an hour and a half here. I think that that's a nice way to conclude, because what you're really showing is, with your answer to the last question, you're really tying everything together with the potential for a global instability when you clinically feel the patient feels, well, I just keep spraining my ankle, right? And we're really, you've really broadened everyone's recognition or sensibility or threshold to that with this wonderful presentation. So I think that's great. So I think we've really covered quite a bit. I think perhaps it's a good stopping point, unless there's anything else you'd like to add, or if Mike or Ali have anything to add in.
No, I think, guys, it's probably the perfect time to stop. What an interesting topic, and we could go on for days. Good questions from the floor, so I think everyone did get what they wanted to get out of the session. So thank you both very much for your time on this session. Much appreciated, as well as all the other sessions that you've contributed to. So very, very thankful for your participation, and from Arthrex and from myself. Thank you guys so much.
Thank you, Michael. Thank you, Ali.
Look forward to seeing you on Orthopedia soon.
Hopefully.
Take care, guys, and thanks very much once again.
Thank you all. Cheers. Cheers now.
Take care, guys.
Thank you.
Bye. Bye, Luke.
Bye-bye, Nassif. Wonderful job. Thank you.
Thanks, man.